Hello, welcome you all and very good evening today. We'd like to invite you to this session on communication. And it is our pleasure on behalf of DOAMS, myself as Dr. M. Osman Ghani, invites you to today's topic on communication. And it is our pleasure actually to invite you all throughout the world to our session today. And as a proud member of Royal College of Physicians, actually this is our pleasure to invite you to this very important session. And I believe that today's participants actually heterogeneous, not in the equal profile, and from different cultures. Those who already joined and those who will be joining a little later, I hope and I believe. So from this introduction, actually, I like to proceed. And again, congratulations from DOAMS. This is the Dr. Osman Academy of Medical Sciences. Actually, we are working for the PACES candidates for the last 7 years, and we are trying our best to develop the candidates in the part 1, part 2 written, and subsequently for the PACES candidates. So many days actually we are thinking to share our views with international candidates throughout the world. And you know that in the meantime, in the world, there is some disaster happened and already it is persisting, the COVID-19 problem. We are trying to get rid of it really. And I think some of you also a little disheartened for examination schedule and other. Even then, actually we like to continue our study and we like to continue our endeavor to support you to achieve the membership of the Royal College of Physicians UK. So with this introduction, actually, as before, many of you are here, my beloved direct students as well, and some are from many countries, maybe new to me, and this is a great pleasure for us. And actually, before going to the topic, and you know, I think not less than me, as you are attending many sessions and seminars by the Zoom devices. Just to inform you very humbly that today's seminar will be mainly divided into 2 parts. The first one will be a short discussion on the pearls of communication, the rules of communication. And this will be an interactive program. So whenever you think to ask me, you know that in the Zoom device, there is an option for hand raising. I think it is better. After hand raising, when you are invited to talk, please switch on your audio so that you can talk, and I will try my best to answer your question. So whenever I give a pause to ask a question, you can ask, or beforehand, you can show your hand. Just to show you that to be a clinician, you know, in the meantime that we are fighting and you are fighting to achieve the 7 skills. And one by one, these are as such: the physical examination skill, identifying the physical signs. The most valuable one, the third one, is the clinical communications, about which we will be talking today. And the skill of the differential diagnosis setting, clinical judgment, managing patient concerns, and the maintaining patient welfare. So from these 7, really, every one is very important. But if we are asked which one is most important and which one is important for all the stations of the PACES, this is definitely clinical communication. And just go beyond our clinical communication with the patient. Actually, throughout the world, we are communicating each other. The human being is communicating with the animals. You know it well. There is a matter of training of the animals as well. And as a doctor, we are communicating to the patient. We are communicating to our senior bosses, our consultants, our juniors, paramedical persons, and each and every member of the health care workers. So to achieve MRCP, actually, we are dealing the patient, we are learning about that only. But in day-to-day life practice also, we must know some rules of communication. Today's discussion, actually, I like to highlight the point 2, what is shown to you. Everywhere in the communication, really, if we want to divide, there are two parts. One is the content of communication. Another is the decoration, what I like to mention as basic rules. So in the station, most of you really possibly busy, or I like to say concerned about the stations, different stations in the exam, history station, communication and ethics, and the examination stations. So I like to tell you now that actually my attention is not like station wise that we will be discussing today on the communication station. Rather, the basic rules of communication, which is very, very vital for each and every stations. And after this introduction, really, we will go for a practice of history station. Again, it will not be a complete history practice or discussion, really, just to implement the rules or the pulse of communication in the practice session. And in the meantime, actually, in the online, we actually submitted a small paper to you in a PDF format. The main points are printed there. I believe that throughout my lectures, throughout my talk, this document will be helpful to just be oriented self about the words and the sentence we are using there. So coming to the word decoration, without decoration, nothing is valuable in the world. So what about the communicating? What about the message we are giving to anyone? And we are serious about giving the information to the patient. It should be decorated one. This is the skills actually tested in your communication station and all other stations. So in the basic rules, going before that, I like to tell that the consultation actually, it's a meeting between two experts. This is interaction between two complicated and differently motivated human beings. It is not much easy matter to tell something to the patient. In the Royal College has set up some rules of the communication which we have to achieve it. And throughout the world, really, many of the mentors are trying their best to help you, to guide you. Anyway, my talk will not be beneficial for the exam, as well as I believe that today's talk will be very much helpful in your day-to-day practice as a general physician as well as a primary physician as well. Anyway, the informant who will be, we know that the patient self, he or she will be the informant, he will give the information to us. But we should not ignore the attendant or other party, friends or other one as informant. And in somewhere, maybe in some examination outside UK, it's very much usual to put a translator, maybe a nurse or doctor itself, or sometime examiner translate sometime if anything wrong to the patient or anything confusing. And regarding again information collection also, it will not be important in the examination, but some video records will tell many things. So many ways of information, but for the exam, patient's attendant, and sometimes translator as well as in the encounter, examiner self is very important. And I will highlight this that when we address, we have to address all together one by one. I will tell you how to do it. So this is actually 23 principles to improve consulting skill. And this is actually set out by Royal Colleges. I like to mention you that this is my pleasure as well as member of Royal College of General Practitioners, side by side, member of Royal College of Physicians. And this is a separate college with their own proud, own entity. They have set out actually 23 principles. Most of you know about that, I believe, I know. But I think that there are some extra points and extra things to be highlighted in these principles, and I hope that you will enjoy it. So these are actually the 23 principles written here. No need to read by yourself throughout. If you want, you can make a snapshot by yourself. Okay. So the first point is meet and greet, introduction in the station. How to do it? Be attentive to the patient as well as attendant, both together. We have to be in the smiling face always. But regarding the shaking hand, now a controversy arises in the corona pandemic season, and now the advice is avoid handshaking. But possibly it, for the time being, again, and throughout the world before the corona crisis also, as a part of the infection control, there is ongoing research also that shaking hand is significantly responsible for the transmission of disease or not. We hope that in future we may get a guideline from the Royal College and other authority about that, the shaking hand. And how to start this? And many of you, I think, I know that you address your patient in a different manners. And if I say you can tell by your own that, for example, good morning, Mrs. Jane, or you can tell that only, good morning, I am Dr. Such and Such. May I confirm your name? This may be one of the way. And but I think in my sense, really, the may I know your name, or may I confirm your name beforehand, actually a doctor candidate has come to know the name in the instruction outside. So in the examination station, we have to save our time as well. So entering the encounter in the room, the examination room. So if we start in that manner, what I like to advise you really from myself, that addressing as good evening or good morning, Mrs. or Mr. Jane, by these simple few words, you are addressing as well as you are identifying. So it will save your time. And patient will be happy that you already come to know the name of the patient. So, you know, in our daily life also, you know someone from beforehand, but you forgot the name. Whenever you just in front of him again, if you know, if you like to know that what is your good name or like this, it may be a little discomfort for this guy, that he may think that this doctor actually know me before, he forgot my name. So in this respect, really, it is my suggestion to address the patient in a manner that, hello, good evening, Mrs. Jane. I am Dr. Such and Such. Another thing I like to highlight is here, in the instruction, you may find that what is you actually, that you are a doctor on duty today or doctor on call. So better to clear in this introduction. I am Dr. X or Y on duty in this ward today, in this clinic today, or I am doctor on call, or I am on call from other departments. Sometime it may happen in the exam. So my advice is to take care of this. So I'm here to talk to you. Is it okay? Just getting a permission and taking care of the well-being of the patient. That are you comfortable? Do you like to invite anybody else in our consultation? It is a part of the confidentiality. And again, is a part of confidentiality in the medical records. Would you mind if I take some notes? Give a pause, let the patient say, okay, doctor, no problem. And boost it up by telling it will be confidential. You will find that your patient will be very much happy. So sometimes the patient thinks that you're writing something, you will transmit it somewhere else. So lastly, actually, how to start the talk. how can I help you? So I just showed you really 5 principles. That means the 5 sentences overall in each and every station. By telling the following these 5 principles, a smiling face up to there. But to inform you that in the examination station, actually, the long sentences may not be practical. This will be a modification of that, really. We will talk in another session, if possible, in future. Just how to start the talk, especially in the history and in the communication station. How can I help you? Many of you, really, you can start in a different manner, no problem. But as a mentor for a long time, but I was thinking that to use some words which are very much palatable and a word giving a comfort and assurance to the patient is better to use like word help. Somebody is telling that I came to know you have this problem. Can you tell more about that? This is also not wrong. So this is a simple word really you are using. But if I say, and this is in custom, and the patient usually understand what do you mean by this? How can I help you? Really, as a doctor, I am here to help you. So this is my suggestion to start with. How can I help you? And in the chamber, you see, it should be the seating arrangement. And already you can see in the examination station, if anybody attended the exam, you already found this in a position, not face to face, directly, a little angular manner they are sitting. And the chair will be of equal profile, equal quality. We can follow in our day-to-day practice as well. There are some information regarding the sitting arrangement. There should not be any barrier. In the exam center also, if you find that there is a barrier, the table is in between, you can arrange your chair by yourself. So there should not be a barrier. The minimum distance on an average, it would be a 1 meter distance. And there should be a narrow angle in between you and the patient. Okay, I think you understand it. And the third principle is the body language and the eye contact. So you see that in a chamber environment that doctor asks something, she's the mother and the son. So if any patient having something private, they feel shy. The head is nodding down. So doctor is to understand what their body is telling. So the message from this picture telling you that they are in shy really. So who is the patient? If patient is the son, you have to request the mother just to be a little away or outside. So this is the body language. In many clinical clues, patient will tell you by their body language. I'm just showing one picture as example. And another thing in the body language, especially for the eye contact, a great clinical clue there may be evident. This is when you are talking to the patient is losing his or her eye contact, then you may think that patient suffering from depression. So the body language can tell many things. I'm actually continuing one by one the principles. In between, again requesting you, if you have any query, please raise your hand. I will give a pause there. I will try to explain the point. So the fourth point is questioning. This is a question. The gathering of the information, the weapon is actually questioning. And we must know about the types of questioning. This is one open question. I already started before. How can I help you? This is very, very open question. When patient tells you that patient having a problem like cough or breathlessness, then you are asking about many questions about the breathlessness, about the cough. So how can I help you? What is the problem like this? And patient can tell you that I have such and such. But if you want to know something else, patient is not telling, you have to close the question. Do you have cough? Do you have fever? Are you losing weight? Whenever the answer is yes, regarding the cough, now we are probing the question, how many days any flame is coming or not, how very often it is coming, where is the diurnal variation, about many, many questions. You are already doing this thing, just not to forget, just to make you organized. I just telling you about the types of question, open question, closed question, and the probing question. Again, something about the questioning, what is prohibited and giving wrong information. This is the leading question. And another one is multi-barrel question. Maybe this thing repetition for many of you. Even then, the learning should be a part of a way of repetition or hammering in the brain. For that, we are continuing our talk really. And if we know also, even then, if we don't practice, the mistake may happen in the exam. The leading is that the question having the answer yes, like I think that you are passing blood with your stool. Is not it like that? Is not it? Means the answer usually will be yes, really. There is a psychological background as well. I don't like to highlight it. And the multi-barrel question, the common question we are using to the patient is asking two questions together. What about your bowel and bladder? So bowel is a part of alimentary system, bladder is a part of urinary system. So if answer is yes, the yes may be confusing to you or to me that this is yes to bowel or bladder, we don't know. The rule is to ask one by one. Again, in the past medical history, do you have diabetes or high blood pressure? Not like that, better to ask one by one. Do you have diabetes? Then answer. Then do you have high blood pressure? Like that. So this is the rules of communication really, the qualities of questioning, the nature of the questioning, and these types of questions should not be asked leading and the multi-barrel question. And during the consultation, really, we have to be silent. But silent doesn't mean telling nothing. This is called facilitating the talk. As a principle, consultation actually is called the patient-centered consultation. Let the patient talk more. So there are many, many ways. I told you, I used a word decoration. Suppose a patient is telling about a very, very severe sad news or sad information. In that time, doctor can say, I'm sorry for that. Just to show sympathy, you know, the sympathy is very good character of a consultation like that. If patient is telling very nicely, you can appreciate, okay, you are telling very nicely, please continue. But one thing is very important is the interruption. Patient is telling, usually the patients or human nature that to tell something irrelevant. In the consultation, your time is very short. Even in the chamber practice also, your time is very short. So we must achieve the quality, how to interrupt a patient, how to interrupt even a patient in the exam as well. So in another session, maybe in the coming talk also, if possible, we like to show you how to interrupt. For example, little even then I am telling you that we can tell to the patient that patient, you are talking about the cough, patient is telling about the road accident, something else happened during her or his journey to the chamber. So we can tell in a manner that, can I make a pause in between our talk? We can talk about this a little later. Can you come to the talk of your cough, please? In that manner, very gently, we can interrupt a patient. So I'm going one by one, and I think it will not take a much time really. This is the reflection. What is the meaning of reflection as a principle in communication? That patient is a patient of musculoskeletal system of gastroenterology. You expect that he will tell about some problem regarding that system, but during entrance, patient telling you that, doctor, I'm feeling very low today. You just observed it. Don't ignore this comment or words from the patient. In between your consultation or the last part, you include it. So anyway, in the exam situation, really, it will not be a great problem for you because you will be entering to the chamber. You will be entering to the examination room. Anyway, it is a part of practice I'm telling you. So lastly, you can ask about the feeling low, what's the wrong with the patient, extra problem. And this is very important about the clarification of the word. Usually, you know about the word, that jargon, using the jargon. We have to be clear about the unclear vowel. If patient use the word, again, doctor should not use such words. There may be difficult water word. difficulties in the water work, what is the difficulties in the urination. And strong diarrhea, what does it mean actually by the patient? It is a diarrhea causing dehydration or not. Again, there are some cues. Cues means patient is using some other words, actually not directly mentioning the word related to the parts of the system of the body. Suppose hormone problem, the young people may tell about their problem in the sexual mating, or even the night pressure. It depends upon the cultures throughout the world in many countries. Maybe patient is here to tell about his nocturnal emission, especially by the young man. So these are the cues. And observational comment also another one in the consultation. You observe that the patient having cough. Patient is not telling about, patient is discussing about his fever and other also, or something problem of musculoskeletal system. So this is also important information. To gather all the information actually, we have to be very aware of that. Patient is not telling, but you're observing. So don't leave it away. Try to ask about the coughing in a manner that I understood you have terrible cough or you're smoking, you know, your patient that he was smoking beforehand. The point 11 is choosing the word by the patient, again the jargon, and choosing word by the doctor should be clear to each other. And this is the jargon, and using jargon, we have to be very cautious about that when we are talking to the patient. You see one example I put here. The teacher is telling how many of you comprehend the term follicular. The teacher is attending the word follicular only, but the listener, the audience thinking, what does comprehend mean? So to make a sentence clear, we have to be very aware that we should not use another jargon. So this is the message for you. And regarding the psychological and the private issue, really, how to start with, I like to ask some questions which may be embarrassing, but important for your disease detection and the treatment. Is it okay? Give a second opinion or second permission about that. Or in indirect manner, can I ask you to describe where you are living now, the living situation, home environment? That means you are giving a signal that you are entering his or her personal life. Who are living with you? So these are some techniques, the psychological issue, and then idea, concern, expectation. Sorry. This is very, very important. And almost in every session, really, the concern is very, very important other than the examination station. But I expanded the word by other things. This is the idea. So in the MRCP, the concern word is very highlighted. But I think that you can make your consultation more delighted, more enlightened by using the word idea. So 3 points are here: idea, concern, expectation. For example, a patient suffering from headache. So asking about the idea, patient thinking about the disease, what is the cause of the headache, patient may think of the tumor. So this is the idea. Concern is that if the tumor, patient will die, or exceptionally, concern may be that what will happen to his or her children after the patient dies. So concern is varied actually. We cannot think that the tumor is a concern for the patient, rather the death of the patient and the consequence to the family members. So we have to identify in the exam about the concern, we have to address it. Anyway, the expectation, the last one, you know, that how can I help you or what can I do for this patient may expect a CT scan of the head, but you are thinking that the scan is not indicated here. This is the responsibility of a physician, and that mismatch between doctor and the patient. So we have to solve it. This is very, very important criteria, you know. Framing and the meta communication in communication context. This is in simple word called the signposting, that I am now asking about some private or personal questions. This is the signposting, just to get the patient ready to discuss about that. And this is like that somebody is guiding to you, go there for that. So in the consultation, if you are guiding a patient to talk about some specific topic, you are telling something as introduction. This is called framing or meta communication. And the sanctioning or appreciation of the consultation. If you find that person having inhaler in the pocket, you are thinking that patient using it, appreciate the patient. You are using inhaler, it's very nice. And you know that the treatment failure throughout the world in asthma patient, a great bulk, the reason is not to use the inhaler in a proper manner. So appreciation, and after appreciation, it will be easier for you to let the patient know how to use inhaler, and he will be very happy from your approach like that. So in the we are coming to the almost the later part of my talk. This is summarizing in the history or in the communication also, even in the station 5. Do you like to add anything else, or do you like to ask anything more like this? Something lapsed, something you couldn't remember to ask, it will be very great weapon for you really, just to gather the information. Sometime surrogates are waiting to tell you something, but unfortunately some surrogate may not tell. Now calculating the diagnosis, you know, many of you, or we can discuss in another one. This is just a thought process working in our mind, that the reason of the breathlessness, to identify the breathlessness may happen from respiratory disease or the cardiovascular disease, or maybe metabolic one, just to correlate the breathlessness with the other symptoms. We will show in the history talk really little. But giving the information in the 3 models, explanation is very important in the management part, you know. So first explore what patient know about that, then you explain, then you again explore. This is the 3E model. If you want, you can make a snapshot. I am not going detail of that. In the management plan, there are few points. Explanation again in the 3E model. Don't be judgmental. That means it may be discomfortable to the patient that you are smoking for that you develop this disease, not like that. This is called don't be judgmental. Reassure always. Linking health belief to the patient in the therapeutic plan, collaborative management, and the exploring understanding of the management. Again, use the 3 model. The finally, hospitalize the patient, refer, and do the safety netting if it is an outpatient department you are working, that after 2 weeks you can come, and if you have any problem, please let me know. This is it is called safety netting, and safety netting is very important really. And the health promotion, sometimes it could be opportunistic. The disease may not be directly related with the smoking, patient having behavior of smoking or the alcoholism, or sometime in the South Asian zone, people having behavior of chewing the betel nut and some leaves also. It is hazardous for the health. So in the later part of the consultation, in the history, in the communication as well, in a specific station, we can tell you in any time that the health promotion is very important part of the management plan. So this is actually in short, the data collection and the management, and actually we are heading for the triple diagnosis, biopsychosocial diagnosis. And in the MRCP, we tell it really problem list. We have to list one by one, you know, many of us, the biologic problem, psychological problem, and the social problem. And the barrier of, sometimes this is a barrier, usually lessly happen in the MRCP, but it's not good. It's good that to know about something, that there may be barrier of deafness, patient cannot hear well, you may be puzzled. For this slide for you really just to have a snapshot, it will be easier for you how to deal with a deaf or hard of hearing patient in this station. There are some principles. It will be easier for you. So actually, I like to end now my one-way talk almost. Thank you very much to be with me really.